Good evening, ma'am.
गुड इवनिंग नेहा।
Yes, ma'am.
अच्छा।
Let me change
आप
my name.
हाँ,
Good evening, ma'am.
या आपको को होस्ट बना दिया गया है।
हाँ हाँ, okay, ma'am.
गुड इवनिंग नेहा।
Yes, ma'am.
अच्छा।
Let me change
आप
my name.
हाँ,
Good evening, ma'am.
या आपको को होस्ट बना दिया गया है।
हाँ हाँ, okay, ma'am.
गुड
मैम ये
इवनिंग।
रिपीट क्यों हो रहा है साउंड? आपको
Yes,
भी आ
ma'am.
रहा है क्या? Let me change
आप
my name. मैम अभी यूट्यूब लाइव नहीं है ना?
नहीं, अभी नहीं है।
हाँ, क्योंकि उसमें कुछ लाइव स्ट्रीम दिख रहा था।
नहीं, वो पुराना है, वो मैं डिलीट करती हूँ बाद में। अभी कुछ गड़बड़ नहीं होने, वो टेस्टिंग के लिए था।
अच्छा अच्छा, ओके ओके।
हम्म। आता चालू आहे.
मैम मैं आपको स्लाइड शेयर करके एक बार
या
देखूँ
प्लीज
क्या?
प्लीज प्लीज, वीडियो भी ठीक है क्या, देख लीजिए।
हम्म। नहीं, मेरा तो वीडियो नहीं भी रहेगा कुछ।
हेलो हेलो.
गुड इवनिंग डॉक्टर श्रुति।
या गुड इवनिंग मैडम. हाउ आर यू?
फाइन फाइन।
यस. हेलो, गुड इवनिंग डॉक्टर नेहा. डॉक्टर नेहा इज देयर?
सी शेयरिंग पीपीटी।
Yes.
ओके.
Okay, these four
वाह,
slides
मस्त दिख रहा है।
and the rest as Shruti has shared with me. सर का फोटो यहाँ पे लगा दिया.
या वाह।
ओके, है ना?
अच्छा, और उसके पहले का तो
पहले का सब ये.
करेक्ट, हाँ। वाह, ये तो 3 स्लाइड्स है, वो तो अपने को वैसा ही दिखाना पड़ेगा, 1 2 3।
हाँ, यस. ठीक है ना मैम?
यस, बहुत अच्छा।
ओके, तो हमेशा के लिए हम लोग ये स्लाइड्स फिक्स कर
हाँ,
देंगे.
और वो
एंड
थैंक यू वाला भी अच्छा है मुझे। लास्ट वाला जो है ना, थैंक यू वाला, वो
हाँ
भी है।
हाँ, बट वो दिखाना है क्या मैम? वोट ऑफ थैंक्स के
नहीं नहीं,
समय
वो
दिखाना है?
वोट ऑफ थैंक्स के समय दिखा सकते हैं, ऐसा कुछ नहीं।
ठीक है.
नाउ वी विल वेट फॉर अदर्स टू ज्वाइन।
इट्स 8:45, अभी है 15 मिनट.
सो मैडम, चित्रा मैडम, am I audible?
या यू आर गुड.
Okay, so vote of thanks will be done by Dr. Ram Bharat sir, right?
जर का डॉक्टर वैशाली नाही राहिल्या तरच. राम भरतला सांगून ठेवलेलं आहे, पण डॉक्टर वैशाली शी जस्ट आस्क मी फॉर CV ऑफ डॉक्टर शैलजा माने विच शी इज गोइंग टू टेल नो. So probably she will join for some time, but if she is not present at the end, she will inform us that she is leaving, and then we will ask Dr. Ram Bharat, he is ready.
Yeah, but while addressing, I need to address Dr. Ram Bharat sir, right?
No.
In the initially?
Initially for what?
as you have mentioned, to welcome all the dignitaries with their name
Yes,
and
yes,
designation.
you can.
That time I can address them.
Yes, yes, definitely.
Yes,
He is
yes.
treasurer, no?
Yeah, right.
तर आपण फोन केव्हा करायला सुरुवात करायची? 5 मिनिटं आधी.
No, we can start right now. कारण वेळ मग जाईल आपला, वेळेत होणार नाही.
येस, येस.
आणि YouTube लाईव्ह स्ट्रीम 9 वाजता
करायचंय,
होईल.
माझ्याकडे आहे,
ठीक
तयार
आहे.
आहे सगळं.
ठीक आहे.
मीटिंग चालू झाली की वी आर गोइंग लाईव्ह सांगते.
Sure. And Dr. Neha, please try to click the photos when all cameras are on. In the initially, like when there are all
Yeah,
dignitaries
sure.
will be
Okay.
present. Otherwise, recording also have photographs.
No problem. I will take photographs. In between also, I will take photographs.
Sure.
So I am not supposed to share anything right now. Huh? Neha is there. She will share all the CVs, and then PPT. If it is not there, if sir gets any issue, then who will share PPT? तो
I
पाठवलं
have
का?
shared on the WhatsApp the PPT.
No.
Good evening,
Doctor?
sir.
Good evening, Vaidya sir.
Yeah. I have shared sir's PPT on WhatsApp. I think Dr. Neha has
Yes,
downloaded.
I have downloaded.
Yes, so you can keep
Okay.
this for backup.
Hello, madam. I will just, switch on my video in a moment. Just give me 2 minutes.
Yes,
Thank
welcome,
you.
sir.
Thank you, sir. Welcome. आपण मी पांढरीकर सरांना फोन करते. दोन कोणी वाटून घ्या.
Dr. Neha, you can call. No issues.
I have to call.
Yeah, like the
Whom do you
call.
want me to call?
Dr. Chitra madam told na to call. So you can call. No issues.
Can you
Okay,
call
Ram
Dr.
sir?
Piyali? Dr. Piyali?
प्याली मैम. Okay, ठीक.
Yes. सर 9 वाजता जॉईन होत आहे. थँक्यू. येस.
Yes.
I'll run the PPT from my end.
Yeah,
Yes,
sure,
sir.
sir.
Yes. Sir, you can try also.
Oh, bhagta हूँ.
If any problem, Dr. Neha can share from our side.
No.
Yes, sir. And Pyali ma'am is joining in next 5 to 10 minutes.
Mhm. Yeah, sharing is not turned on. The admin they will have to allow sharing. Yeah, now I think it is on.
Hello, welcome, Dr. Agrawal, sir.
Yeah, I think you should be able to see now. Yeah?
Yes, sir.
Yeah.
Oh, okay. Fine.
The slides are moving also. I think so. Yeah, it's moving.
Good.
Good evening, Pyali ma'am. Ma'am, you are on mute.
Hello, everybody. Hi.
Satish
Hello. Good evening, madam. Good to
Good
see you.
evening. Good evening there. All of you, such lovely ladies. Come on.
Thank
Good to
you.
see you all.
Yeah.
सतीश सर गुड इवनिंग. नहीं, पहली बार मिले हैं तो गुड मॉर्निंग.
Satish Agarwal, sir. Good evening, sir.
नहीं, मैंने गुड मॉर्निंग बोला सर को. पहली बार मिले हैं दिन में. Satish sir, good morning.
I think, sir,
Good morning.
yes, yes.
So good to see you, sir.
Just
Piyali ma'am, you are
हाँ,
always adolescent. You want to break the rules. Early adolescence.
अभी जाता ही नहीं है, क्या करें? So
That's
we have
nice now, ma'am.
very
हम
good.
तो
You
You
know,
should be like an adolescent.
हम तो एड्रेस भी करते हैं ना, तो लेडीज नहीं बोलते, गर्ल्स बोलते हैं इनको. हाँ, they're all pretty girls.
देखो देखो. So we have Dr. Sandeep Vaidya.
Yeah,
Dr.
madam.
Sandeep,
I'm here.
Yes.
good
you're
evening, sir.
practicing adolescent medicine.
No, I am a pediatric orthopedic surgeon.
You're a pediatric
Yeah.
orthopedic.
So today I will just deal with some, common OPD conditions which would, present to a pediatrician's OPD.
Right.
Yeah.
I mean, I'm raring to listen to you
Yeah.
because these are not often addressed actually.
So that is our idea.
So I practice in Thane, and I am teaching, I'm an assistant honorary at Wadia Children's in Mumbai.
Okay, at Wadia. Wadia mein, we have friends in Wadia as well, the pediatricians there.
Yeah, sure.
I think Dr. Nitin is in Wadia.
Yeah, Nitin Shah. Yeah,
Mm.
he's a visiting faculty.
Mm. There are some more as well.
Yeah,
I think
Parmanand Andalkar is there.
Parmanand is now not attached to Wadia, but I work with him at Jupiter Hospital in Thane.
Okay.
Yeah, but
Initially, he was there at Wadia.
he was he was there in Wadia for many years. In fact, I first met him when I was a resident in Wadia. So that time he was a lecturer in the PICU. That's how I got to meet him, and then we continued our acquaintance after I joined Jupiter Hospital.
okay. So you must be knowing Madam Armeda also.
Yeah,
She's doing
Armida
palliative
madam,
care.
I know because I'm a UG from Sion Hospital where she
Oh,
was.
then you
Yeah.
know her
So
well.
that was in from 94 to 2000. I spent in the Sion Hospital doing my MBBS. So that's when she was the head of neonatology at that point of time.
Yes, she was in Sion for a long time.
Yeah.
And then when she picked up palliative care, we were sent from IAP to learn palliative care from
Oh,
her.
okay. Yeah.
I was really impressed. She's a force actually. And this is the first time I'm so happy that someone has actually got this Padma Bhushan, and
Great honor.
it's a Padma Shri, I
Great
think,
honor.
and Padma Shri to the right person.
Yeah.
Sometimes ना लगता है कि खरीदे हुए होते हैं. But this one is genuine. She is so genuine.
Yeah.
Truly said.
She had been to Amravati also for setting up a human milk bank.
I know, sir. She was the one who started Sneha, na?
And
That was the milk bank was her baby in Sion.
Yes.
she started at Sion only, the first milk bank in Asia.
Acha, in Asia, sir? I thought in
Asia.
India.
No.
In Asia.
We started the milk bank in Asia, that was Sion. And then the things spread to all over. At Maharashtra, we are having at least 21, 30 milk banks. In Amravati only we have 4 milk banks, human milk banks.
Abhi to sir, UP में it's so difficult. The first one they set up in KGMU, वही ठीक से नहीं चल पा रहा है. Acceptance factor है sir यहाँ पर.
इसे बोलो मोटिवेशन थोड़ा लगता है मैम. एक बार वो हो गया तो फिर हो जाएगा.
Madam, you are from KGMU?
Yes.
One of our ex-fellows, Dr. Suresh Chand, he is now there in the orthopedic
I know him.
department.
I know him.
He was
I'm
my
now
fellow.
presently working in SGPGI for a long time.
Okay.
Just retired from SGPGI, got reappointed again. I said, छोड़ दो रे बाबा. But they said कि नया आएगा तब तक. Hi, Shailaja.
Hello, Piyalidi. How are you? Good
All
evening, all.
Yeah,
The
good
great
evening, madam.
academician has arrived.
Good evening.
Good evening, ma'am.
Good evening.
Namaskar.
I'm in OPD. Actually, I will just. Hello, sir. Good evening.
Yes,
I
yes.
am also in OPD, ma'am.
Yeah, I will just switch off my camera and finish.
Okay.
Yeah, sure.
Thank you. Thanks for joining.
So AHA is a All India association?
It's an All India association. It's a subspecialty chapter
Yeah.
of our IAP.
Okay.
We have around 3,500 members all over India.
Okay. Okay.
Gradually increasing. It's becoming one of the largest subspecialty. It was just next to ID. Now we are at par, infectious disease.
Okay.
People
Almost
seem to
bigger
be
than
interested.
ID. Kelvin is bigger than ID. I think the number has increased.
Biggest is ID, yes. But we are at least now becoming gradually shoulder to shoulder, sir.
Really appreciate Chitra Man's work. No? She has drafted each minute to minute this thing proceedings. Highly appreciated.
We need people like that, sir, who are very meticulous and who actually have done that. I had also asked for the flow of events and she sent that to me.
So
Shruti sent it actually.
I preserve it. It will be very often.
अच्छा है ना sir? You know where you are.
That's
Piyali ma'am is the real energy behind our all enthusiasm.
Come
In
on.
a crowd also, she always recognizes, gives smile, talks something. I really appreciate, ma'am.
Thank you.
Being a national chairperson, still, you're same. Thank you.
जो चेयर पे आता है ना चित्रा, वो सब लोगों का प्यार मिलता है तभी आता है. अदरवाइज आई डोंट थिंक उसमें कोई कैपेसिटी सिंगल हैंडेडली वर्क करने की होती है. इट्स ऑलवेज ए टीम. द एनर्जी कम्स फ्रॉम द टीम.
full leadership quality.
सर के साथ मेरा ना फैन क्लब है. सर मेरे को अच्छा अच्छा बोलते हैं, मैं सर को अच्छा अच्छा बोलती हूँ.
नहीं हमारा स्वार्थ है इसमें. वी आर सीइंग द फ्यूचर प्रेसिडेंट इन केएमएल. बीपी तो हो गया,
सर
बस एक
सर
पूछी है. हाँ.
Dr. Neha, can we start the music and flyer? It is 8:58.
Sure, ma'am.
Yeah, thank you. Shall I start live streaming? आप बोलिए तब करेंगे.
2 minutes to go ना.
Yeah.
हाँ मैम,
हाँ.
मैं स्टार्ट करती हूँ शेयरिंग. म्यूजिक जैसे ऑन होगा देन यू कैन गो लाइव.
Yeah. It's already live on YouTube, madam.
No, a recording I have not done. Yeah.
Okay.
Ma'am, shall we start?
It's 1 minute to go.
Yeah.
You can start, ma'am.
Thank you very much. We are having our second webinar, and Happy New Year to all the dignitaries and delegates who are watching live on YouTube also. We as Maharashtra AHA team 2026 have planned to make aware various subspecialties issues which are prevalent in adolescents apart from mental health. Adolescence is a unique stage of development and it's important time which decides about the future of good health, which is very, very important as an adult. Early diagnosis and timely interventions do matter. So, in our today's topic, adolescent orthopedic problems, we are having to have young and enthusiastic moderator and scientific committee member, Dr. Shruti Kalkekar. Over to you, Dr. Shruti.
Thank you very much, Dr. Chitra Kulkarni, madam, for those thoughtful and inspiring opening remarks. Good evening, everyone. On behalf of MAHA AHA and Central AHA, it's my privilege to warmly welcome Dr. Chitra Kulkarni Madam, Chairperson 2026 MAHA AHA, Dr. Satish Agrawal Sir, Chairperson for today's academic session and Senior Pediatrician Amravati, Dr. Jayan Pandrikar Sir, Chairperson-elect 2027 MAHA AHA, our chief guest, Dr. Piyali Bhattacharya Madam, Chairperson-elect 2025 Central AHA, our guest of honor, Dr. Shailaja Mane Madam, past Chairperson 2025 MAHA AHA. We also extend a warm welcome to Dr. Sushma Desai Madam, Chairperson Central AHA, who will bless today's academic program. Dr. Shamik Ghosh Sir, Secretary Central AHA. Dr. Vaishali Shirshetty Madam, Secretary 2026-27 MAHA AHA. And Dr. Ram Bharat Sir, Treasurer MAHA AHA 2026-27. A special welcome to our esteemed speaker, Dr. Sandeep Vaidya Sir, Senior Pediatric Orthopedic Surgeon, Pinnacle Ortho Center, Thane. And along with all respected dignitaries, senior members and participants who have joined us this evening on Zoom and YouTube Live for MAHA AHA monthly academic activity. As we begin this academic session, today's webinar focus on adolescent orthopedics with emphasis on identifying adolescents who require timely referral. Participants will learn to recognize common orthopedic problems, identify key red flags, and differentiate normal variation from pathological conditions. We will also highlight urgent conditions and the importance of interdisciplinary collaboration for better adolescent health outcome. With this focus, let's begin today's sessions. Few housekeeping instructions. Kindly keep your audio muted throughout the session. Please post your questions in the chat box, and selected questions from Zoom and YouTube Live will be taken during question answer sessions. It's now my privilege to invite Dr. Chitra Madam to introduce the chairperson for today's academic session, Dr. Satish Agrawal Sir. Over to you, Madam.
Yes, thank you very much, Shruti. Dr. Satish Agarwal, sir, we know as a very humble person from Amravati, and he is right now chairperson, Environmental and Child Health Chapter of IAP. ECHC. He was president of IAP Amravati from 2012, having numerous articles in newspaper for last 25 years. That way he has contributed to the child health in a big way. The children who had read that newspaper and their parents, they are now adults and they themselves are parents, and contributed to Coffee's SIP book of ECHC, textbook of respiratory medicine, medical legal textbook, guidelines for parents and childhood obesity in 2021. And he got felicitated by Central IAP in 2018 for social awareness, which I have just discussed with you, and received Lifetime Achievement Award by IAP in 2021. Sir, welcome you to this prestigious webinar of MAHA AHA. Please unmute, Dr. Shruti.
Thank you, ma'am. May I now request Dr. Jayan Pandrikar Sir to kindly introduce our chief guest, Dr. Piyali Bhattacharya Madam. Over to you, sir.
Shruti. Thank you, Dr. Shruti. Dignitaries on the Zoom platform and of the Zoom platform who are watching this. It's my proud privilege to introduce our own Central AHA chairperson-elect, Dr. Piyali Madam. We all know her. She is a dedicated adolescent pediatrician. She is presently working at a Sanjay Gandhi Postgraduate Institute of Medical Sciences at Lucknow. And she's the chairperson of State AFI Committee on Immunization at Uttar Pradesh. She has been awarded many orations, almost 8 orations, prestigious orations she has awarded, and she has delivered at various national and international conferences. And most important thing is she has received a fellowship of Royal College of London in 2019, and she has been awarded fellowship of Indian Academy of Pediatrics, that is FIAP, in 2015. So with this brief introduction, I present you Dr. Piyali Bhattacharya Madam. And Madam, we welcome you on the platform of Maharashtra AHA. Thank you very much.
Thank you, sir. I now invite Dr. Ram Bharat, sir, Treasurer, MAHA, to introduce our guest of honor, Dr. Shailaja Mane, madam. Over to you, sir.
Is Dr. Vaishali Shirshetty present? She is having some issue in the family, so probably she was not able to join. They had some problem in the family,
Chitra,
and she was traveling.
Chitra, it's okay.
No, Ram,
problem.
Dr.
You go
Shailaja
ahead.
Mane, yeah, I will introduce.
I'm very thankful to Chitra and entire team, and we give her many best wishes. Congratulations and best wishes for inviting me as a guest.
My privilege to introduce
And
my teacher, Dr.
I think we
Shailaja
should go
Mane.
ahead and
No,
we should
Dr.
go
Ram
ahead
Bharat
and
is
learn
introducing
up
you.
from the
Just a
experts
second.
now, actually.
No, not a issue. Dr. Ram Bharat, our treasurer of MAHA, will introduce Dr. Shailaja.
It's my pleasure to introduce my teacher, Dr. Shailaja Mane Madam, who is professor and head of department and founder and director of Yashoda and Human Milk Comprehensive Lactating Management Training and Research Center at D.Y. Patil Medical College and Hospital and Research Center, Pimpri, Pune. She is consultant pediatrician and adolescent health specialist. In Madam is having Siddhi Children's and Teens Clinic at Chinswad, Pune. Areas of interest: adolescent health, non-communicable disease, and human milk banking and bioethics. Madam is founder president of IYCF Maharashtra IP State Branch, founder and director of Yashoda Human Milk Bank Pune, chairperson Maharashtra Adolescent Health Academy 2025, secretary Bioethics Unit UNESCO chair, head student wing of Bioethics DY Patil University, in charge Association of Child and Adolescent Health, that is AKKI Pune, and member of WHO Adolescent Health Research Network of India. And Madam has numerous national and international publications, and Madam recently has received a prestigious IMA award, that is Dr. Garg Award, which is for excellent service in medical health care and medical academics. This award is recently awarded to Dr. M.G. Garg All-Time Achievement Award for 2025 by IMA, recently been awarded in Ahmedabad. So with this short introduction, I introduce Dr. Shailaja Mane, Madam.
Thank you. Thank you, Dr. Ram, for sweet words. Thanks a lot.
Thank you.
Thank you, sir. We also
Welcome, Dr. R.N. Sharma, sir.
Yes.
Thank
May I
you.
We
request
also
you
welcome
to
Dr.
send?
Preeti, madam.
Yeah.
Good evening, Preeti.
May I request Dr. R.N. Sharma, sir, to say a few words?
Thank you very much for inviting me, and I hope this is a good initiative from Maharashtra AHA, and I wish all the best for the future endeavors. Thank you very much.
Thank you, sir. We also sincerely acknowledge the presence of our senior members and office bearers, including Dr. Sushma Desai, Madam, Dr. Shami Ghosh, sir, along with all dignitaries who have joined this evening. Dr. Sushma Desai, Madam.
I don't see madam on this.
I could see Dr. Preeti Galgali had joined.
Yeah.
Dr. Preeti?
Yes.
Thank you very much. Yeah. Yeah, please.
Welcome,
Yeah. Thank you so much. I think we are in the process of cutting down inaugural programs to the minimum. So I think we can start if it's okay with everybody. Thank you so much for
Thank
inviting
you,
me. I'm
Dr.
looking
Preeti,
forward to the talk.
for so nice words.
Thank you, Madam. We now move to the academic highlight of today's program. It's my honor to invite our chairperson, Dr. Satish Agrawal, sir, to kindly introduce today's speaker, Dr. Sandeep Vaidya, sir, Senior Pediatric Orthopedic Surgeon, Pinnacle Ortho Center, Thane. Sir, over to you.
Thank you, Dr. Shruti ma'am. My sincere thanks to the chairperson MAHA, Dr. Chitra ma'am, secretary Dr. Vaishali ma'am, Today's chief guest, Dr. Piyali ma'am, and guest of honor, Dr. Shailaja ma'am. Central AHA Chairperson, Dr. Sushma ma'am, and Maharashtra AHA core team member, Dr. Jayan sir and Dr. Ram sir. I have been given the responsibility of introducing today's speaker, Dr. Sandeep Vaidya sir. He is a consultant pediatric orthopedic surgeon. After doing his MS orthopedics from St. GS Medical College, Mumbai, he did fellowship in pediatric orthopedics from Wadia Hospital, Korea University, Singapore, and USA. Since last 18 years, he is doing consultation and is honorary at Wadia Hospital, Pinnacle, and Jupiter Hospital at Thane. He has performed more than 10,000 surgery during his illustrious career. His special interests are in clubfoot, that is CTU, congenital territorial spinovirus, congenital pseudoarthrosis of tibia, developmental dysplasia of hip and cerebral palsy. Most other conditions we already know, but have never seen, so it is because of geology. He has got tremendous academic contribution, having published more than 30 papers in various journals. He is the co-author of a book and is a faculty in demand at national level. He is a teaching guide for pediatric orthopedic fellowship at MUHS, a very prestigious post indeed. So, because I've been given 1 minute time only, so I invite Dr. Sandeep Vaidya sir for his deliberation. Please welcome Dr. Sandeep Vaidya sir.
Thank you so much. Thank you all the dignitaries of AHA. And without much ado, I will now share my screen and start the talk. So the agenda for today is to discuss common orthopedic conditions seen in adolescents by a practicing pediatrician. So how I plan to take this session forward is that I will present 5 common OPD scenarios with which an adolescent may present in your OPD, and we shall discuss number 1, how to approach each of these scenarios. Number 2, what can be done at the primary care physician level in order to treat these cases, the basic treatment. Number 3, what are the red flags to look for, and when should these cases with red flags, when should they be referred further for proper orthopedic management. So with that, we shall go over to our scenario number 1, and that is an extremely common scenario that we see, that is an adolescent with flat foot. So consider this case, a 12-year-old male child with a bilateral flat feet. Parents are extremely concerned about the appearance of the feet, which has been there since early childhood. However, the parents feel that this appearance has been aggravated since the past 1 year. So first, before we go on to how to particularly manage this particular case, let's understand what is flat feet. So in our foot, there are 3 arches, out of which the most important arch is the medial longitudinal arch. I'll just take the pointer here. Yeah. So the most important arch of the foot is the medial longitudinal arch. Now, flat foot is a condition in which there is loss of the medial longitudinal arch. So when the child is standing, the sole is in contact, the medial border of the sole is in complete contact with the ground. Additionally, if you look from the posterior aspect, the heel will be in slight valgus with respect to the leg. And because the heel is in valgus, you get what is known as a too many toes sign. That is, almost all the toes will be visible when we look at the foot from the posterior aspect. So that's the definition of flat foot for you. Now, when you see a child with flat foot in the OPD, how do you approach? So I suggest that whenever you see a child with flat foot, ask yourself 2 simple questions. Number 1, is this flat foot flexible or rigid? And number 2, is the flat foot symptomatic, or the parents are only concerned about the cosmesis? So let's take each of these points one by one. Number 1, is the flat foot flexible or rigid? So let's first understand what is a flexible flat foot and what is a rigid flat foot. So flexible flat foot, most of the cases that you see in your outpatient department, in fact, more than 95% of the flat feet that you see are going to be flexible flat feet, which means that if you observe the child on the examination couch, when the child is not bearing weight on the foot, he will have a good arch. It is not that the arch is absent. However, the moment you ask the child to stand on weight bearing, this arch collapses and the child develops flat foot. So that's flexible flat foot for you. Contrast that with this condition called rigid flat foot, which is seen in less than 1% cases, I would say, where the foot is flat even in a non-weight bearing position. So remember, what is the importance of this differentiation between flexible and rigid flat foot is, rigid flat foot is due to an underlying bony deformity and almost always requires referral to orthopedic surgeon for orthopedic correction. Okay, so I hope we are clear over here that most of the flat feet that you see are going to be flexible flat feet. But there are a few more tests that you can do in order to differentiate between the two. Number one is ask the child to stand tiptoed. And in the tiptoed position, if the arch is restored, it means you are dealing with a flexible flat foot. This is not a rigid flat foot. Another simple test which you can perform is the Jack's toe extension test. So on the examination couch, just dorsiflex the great toe, and if the arch is restored, then you are dealing with a flexible flat foot. This is not a rigid flat foot. The third clinical test that you can perform is to test for subtalar joint mobility. And if the heel valgus is easily correctable passively, then this is a flexible flat foot. Okay, so this is how you can differentiate between flexible and rigid flat foot. Now, having discussed that, let's come to the second point. Is your flat foot symptomatic? And for that, let's first understand that flat foot, if you do a population-based survey, almost 20% of the adult population of this world have flat foot, which means almost 1 in 5 patients, 1 in 5 persons in this world has flat foot. But most of these flat feet are asymptomatic. They don't have any symptoms. And therefore, many authors, they consider that asymptomatic flat foot is just an anatomical variant and it is not a pathology. And it follows therefore that if it is an anatomical variant and it is asymptomatic, then you don't need to treat flat foot. Okay? So the simple rule you need to follow is flat foot needs to be treated only if it is symptomatic. You don't need to treat a flat foot for cosmetic purposes alone. Okay? So let's next come to what is symptomatic flat foot? What are the symptoms of flat foot? So the first symptom of flat foot is pain. But it is necessary to understand what is the location of this pain. So in a flat foot, you will have pain typically at two bony points. One is medially along the uncovered head of the talus. This is the talus bone. And if you have tenderness over here and the child has flat foot, then this pain is because of flat foot. The other pain can be laterally at the level of the sinus tarsi. So if at these 2 points, a child with flat foot has pain, then this is a symptomatic flat foot. Many times in the OPD, we get, children or, parents who bring along their children who have knee pain or who have calf pain, and they attribute that to the flat foot. So remember that knee pain and calf pain has no relation with flat foot. It is a misconception that, flat foot leads to knee pain, calf pain, back pain, etc. Okay. For a flat foot to be called symptomatic, the tenderness has to be at these bony points. That is the primary symptom of a flat foot. The other symptoms are difficulty in shoe wear, which may lead to recurrent shoe sores. Now, the importance of identifying a symptomatic flat foot is symptomatic flat feet need treatment. Okay. So, with that background, let's go to what is the conservative treatment which you are going to use as the first line treatment for symptomatic flat foot. So, the first line treatment is prescription of medial arch support insoles. Remember that these insoles need be prescribed only for symptomatic flat foot. It does not need to be, prescribed for all, cosmetic flat foot that present in your OPD. The importance of prescribing of insoles in symptomatic flat foot is that while weight bearing, these insoles they support the arch and therefore it may control the symptoms. However, it is a misconception that an insole will help to restore the arch. That does not happen. There are multiple studies which have proven that though insoles may bring about symptom relief, the arch does not develop because of the insole. The other important thing or the simple thing that you can prescribe for a child with symptomatic flat foot is exercises to strengthen the intrinsic muscles of the foot, because these are the muscles which maintain your arch. So what are the exercises which you can prescribe? Number one is towel scrunch, that is just pull the towel towards you with the toes of the feet. Number two is picking the marbles with the toes and dropping them into the bowl. Number three is ask the child to walk tiptoe for maybe 5-10 minutes in the morning, 5-10 minutes in the evening. Number four, roll the foot over a tennis ball. And number five, ask the child to walk on sand. These simple household exercises may help to strengthen the intrinsic muscles of the foot, which in turn may help to develop the arch over a period of time. Okay, so these are simple things which you can do at your level in your OPD. However, there are a few scenarios where, despite giving a good trial of conservative management, maybe for 5 months, 6 months, you are given conservative treatment, the child is still symptomatic, and these are the select rare few cases which may require further referral for orthopedic correction. And in such cases, I won't go into the details of the surgery, but the surgery that is performed in this particular scenario is a surgery called a calcaneal lengthening osteotomy. To put it in simple terms, the calcaneum bone is cut at the level of the anterior facet and a bone graft is inserted over there in order to lengthen the lateral column of the foot. And this in general is an extremely gratifying surgery, has got very good results, but it should be used only in select cases, only in cases where the flat foot is symptomatic and the flat foot symptoms have not resolved despite an adequate trial of conservative treatment. That is the only place where this surgery should be employed. Finally, just before I finish this section on flat foot, a quick word on rigid flat foot. As I mentioned, a rigid flat foot is due to an underlying bony deformity, and almost always a rigid flat foot is symptomatic and requires surgical treatment. So in this case, you can see that this child had a rigid flat foot, and if you look at the X-ray, you can see there is something called as a tarsal collision, which means between the navicular and the calcaneum bone, there is an abnormal bridge of bone which is connecting these two bones. Now what this bridge of bone does is it prevents the normal mobility of the foot joints, and therefore it leads to stress and therefore it leads to pain. In such cases, the treatment is excision of the tarsal collision. So we go down to that tarsal collision and we excise it. So this bony bridge over here is now excised, and that restores the mobility of the foot joints and it relieves the patient of the pain. So that was about rigid flat foot in short. So with that, I will conclude this section on flat foot. Let's again, summarize what I just said. Most of the flat feet that you see are going to be asymptomatic, flexible flat feet, and these don't need treatment. Okay, flat feet should not be treated just for cosmetic purposes. Only symptomatic flat feet, that is rigid flat feet, and a small percentage of flexible flat feet need to be treated. Again, the initial treatment is always conservative, which consists of insoles and exercises to strengthen the intrinsic muscles of the foot. And rarely surgery is needed for failed conservative treatment. So that was our first, OPD scenario, adolescent with a flat foot. Do you want me to stop over here and we take some questions, or shall we do that at the end?
No, sir, please
We-
continue.
End of the
In
session.
end. Questions in the end.
Right. So let's go to another extremely common scenario, and that is an adolescent with a knee deformity. And when I talk about knee deformity, it is either a valgum deformity, which in a layman's word layman's language, you can call it as knock knees, or it is a Warren deformity, which we call as bow legs. Okay. Now, again, over here, how do you approach a child with knock knees or bow legs? So here again, I suggest that when such a child you see in the OPD, ask yourself these questions. Number one, is this a normal deformity? Normal meaning physiological. Number two, you have to identify whether this deformity is worsening, that is it progressive, or is it improving, that is resolving over a period of time. Number three, you have to rule out underlying etiology, and in most common underlying etiology is nutritional rickets in our country. Okay, so you have to rule out nutritional rickets. And number four, as a pediatrician, you have to decide which of these cases you have to refer for orthopedic correction and when. So let's take up each of these questions one by one. Number one, is this knee deformity normal? So not every case of knock knees or bow legs is abnormal. And to identify what is normal, this is a chart which I am sure you all must be, well versed with. You all must be aware of this chart. So what does this chart tell you? This tells us that any child where at the time of birth there is a varus deformity or there is a bow legs deformity at birth, in the second year of life, as the child starts walking, starts ambulating, the bow legs deformity gradually starts correcting. Between the age of 2 to 3 years, the angle between the thigh and the leg, it becomes zero. It becomes neutral. From here on, as the child grows older, the thigh leg angle gradually goes into a valgus and the child develops a knock knees which reaches a peak angle somewhere between the ages of 3 to 4 years. And after this, again, the angle starts decreasing. The valgus angle gets decreasing. And an adult angle of around 6 to 8 degrees of valgus is achieved sometime between the age of 6 to 8 years. Now, if you are aware of this normal progression of the thigh leg angle, anything which does not fall within these parameters, that would be considered as an abnormal bow legs or an abnormal knock knees. The second point that you have to identify is your deformity progressive or resolving? And for that, you will have to see the child serially over a period of time, maybe, reassess the child every 3 monthly and at every visit, what you should do is you should note down what is known as the thigh leg angle. Very simple, it's an angle between a line extending from the anterior superior iliac spine to the center of the patella and from the center of the patella to the center of the angle. So measure this angle. This is known as the thigh leg angle. And if on every visit you find that this angle is worsening, then you know that you are dealing with a progressive or worsening deformity. On the other hand, if the angle is improving, you know you are dealing with a resolving deformity. Other simple measurement you can rely on is, in case of bow legs, you can calculate the what is known as the intercondylar distance. That is distance between the medial condyles of the two knees. Okay, so that you can measure, you can serially measure on every visit. And in case of knock knees, you can measure the intermalleolar distance. That is, with the knees touching, calculate what is the distance between the two malleoli, and you measure this distance at every visit. If this distance is worsening, you know you are dealing with a progressive deformity. Next, you have to identify whether there is any underlying etiology to this deformity. And the most common etiology in our country, obviously, is nutritional rickets. To identify whether the child has nutritional rickets, the basic investigations that I routinely do is an X-ray of both knees AP. And on X-ray, what you look for is the physeal widening and the metaphyseal splaying, cupping, and fraying. So irregularity, cupping, and splaying of the metaphysis and widening of the physis. These are the radiological signs of active rickets. I'm sure you all are aware of this. And in the blood test, you would do a baseline serum calcium, phosphorus, alkaline phosphatase, and I would do a serum creatinine level to rule out the extremely rare scenario of dealing with a renal, osteodystrophy or something like that. Okay, I routinely don't even ask for a vitamin D level because these tests would be sufficient to give me the diagnosis. And vitamin D, as you know, it is quite a costly test. But on the basis of these tests, you can have a diagnosis of nutritional rickets. Now, once you identify that a child has an underlying active rickets, nutritional rickets, the first line management is always medical management, and you have to treat the rickets. And you all know how you treat the rickets with calcium, vitamin D supplementation. I won't go into that. In fact, you could teach me that. The question that you should ask is, you see, nutritional rickets, once you start the therapeutic dose of calcium and vitamin D, it heals within a period of say 6 to 12 months max. What do you do after that? The deformity that is there, do you need to correct each of these deformities surgically? Or is it likely that once you correct the rickets medically, is the deformity going to correct on its own? That's a question that needs to be answered. So from our experience, that not all deformities in rickets need surgery. Many of them can remodel. For example, see this young child, this is only 20 months old child, but I'm presenting him in this, webinar on adolescent orthopedic. And he had an active rickets at presentation. We treated with, calcium, vitamin D supplementation. And over a period of time, once the rickets healed, the deformity also remodeled. So not all, deformities in healed rickets need surgery. Anecdotally, we know that if the deformity is in a younger child and the deformity is of a lesser magnitude, the chances of remodeling are better. But this is a recent article which came out in the Journal of Pediatric Orthopedics just about 3-4 months ago. And this gives us some figures to go by. And what it tells us is that if the age of the child is more than 8 years, then the chances of remodeling significantly decrease. Also, if the deformity is severe, which means that a valgus angle is more than around 15 degrees or a varus angle is more than around 10 degrees, then it is unlikely to remodel. Therefore, if my child at presentation, the age is more than 8 years or the deformity is more than say 10 to 15 degrees, then they should be referred for orthopedic correction. Now, that is, till this point, you are managed. Now, over here, now I will just explain to you that once it is decided that the child needs orthopedic surgery for correction, how do we as orthopedic surgeons manage these deformities? So, our decision making mainly depends on how much growth is remaining. If the growth remaining is more than 2 years, then we can treat these children by a simple surgery known as growth modulation. On the other hand, if the growth remaining is less than 2 years, then we need to perform a surgery known as osteotomy. The question is, how do we identify the growth remaining? And for that, we rely on the skeletal age. We don't rely on the chronological age, we rely on the skeletal age. And we as orthopedic surgeons generally prefer to calculate the skeletal age by using this method known as the Sauergren method, which is based on AP and lateral elbow x-rays. So we obtain AP and lateral elbow x-rays, and each epiphysis around the elbow is then scored. A total of this score is then taken and it is then, matched against a corresponding chart, which then gives us the skeletal age. And based on the skeletal age, we can then determine whether the growth remaining is more than 2 years or less than 2 years. So let's take the first scenario where the growth remaining is more than 10 years. So look at this about 9-year-old girl. She presented initially with nutritional rickets. The new rickets has been treated, but she has a severe residual deformity after the healed rickets. So in this case, we do this surgery, which is called as growth modulation. And this growth modulation is done by application of these implants called the 8 plates. Now, the principle of this, surgery is very simple. What we are doing by, application of this implant is that we are temporarily blocking the growth of the inner half of the growth plate. The outer half of the growth plate continues to grow. And as this happens over a period of time, over the next 12 to 18 months, the screws diverge and the deformity corrects. And once the deformity is fully corrected, the screws are the implant is then taken out. So this is growth modulation surgery for you. Another similar case I will show you now. This is a 11-year-old boy, again, presenting with a post-rachitic genu-valgum deformity. In this case, also we did a growth modulation, but we applied a different implant. We used something known as the PET screw, but the principle is the same. With the screw, we are blocking the growth of the inner half of the growth plate. The outer half of the growth plate continues to grow, and as that happens over a period of time, the deformity gets corrected, and then the screws are taken out. Okay. Now, as I said earlier, okay, growth modulation is applicable for if the growth remaining is more than 2 years. And here it is again, I re-emphasize, it is very important to calculate the skeletal age, and that I will illustrate with this case example. So this was a girl who presented with a genu valgum when she was around 9 years 8 months old. The error we did over here is we assume that she, chronologically being 9 years 8 months, she would have sufficient growth remaining, and therefore without calculating the skeletal age. Unfortunately, this child, within 3 months of surgery, she had a minarch, and therefore she had a premature facial closure, and therefore even about 3 years after the surgery, it failed to correct. So this has to be borne in mind, that the decision whether you're going to do a growth modulation depends on the skeletal age and not chronological age. This case also emphasizes the importance of early referral. So if this child was referred, say, 2 years earlier when her deformity was first noted, then probably the growth modulation definitely would have succeeded in that particular case. Okay, so early referral is extremely important once it is decided that this deformity is going to need surgery. So what do we do in these late presenting cases? And we see many of them where the growth remaining is less than 2 years, or they have come after the growth plates have already closed. And in this case, we have no option but to perform a more extensive surgery, which is called an osteotomy. And osteotomy simply means that the bone is cut at the level of the deformity is corrected, and then it is fixed with plate and screws. And an osteotomy also gives good results cosmetically as well as functionally. But the question is that, it is a much more extensive surgery. The period of rehabilitation, recovery is much longer. And this can be avoided if these kids are referred earlier and they are treated earlier. And that is the main message that, needs to go across. Sometimes we come across very severe deformity. So now this is an unfortunate story. Now this is a 21-year-old female, had the deformity right since adolescence. For some reason, received poor medical advice that it is not advisable to correct the deformity, because it may lead to loss of knee range of motion. Now, in this case, as you can see, the deformity is very severe, and in these cases, it is dangerous to correct the deformity at one go, because then what happens is you may end up excessively stretching out the blood vessels and nerves as well, which can be dangerous. And therefore, in these cases, we do what is known as the gradual correction. So we apply the ring fixator, and then we gradually correct the deformity by turning the knobs on the ring fixator. And over a period of time, the deformity gets corrected. So this lady had a good correction, but the question is that, again, this could have been avoided. This could have been treated with a much lesser surgery if she had come earlier. Secondly, this was an extensive reconstruction. It required almost 1.5 years for the deformities of both legs to get corrected. So the message is refer early. So again, to conclude this section, in genu varum or valgum, if there is an underlying active rickets, medical management of rickets is the first line. If the child is less than 8 years and deformity is not too severe, then it may remodel after medical management. However, if the child is more than 8 years age, please don't waste time. Refer straight away for orthopedic management. Early referral facilitates minimally invasive surgery, that is growth modulation as I showed, as compared to more extensive surgery which may be needed if the growth remaining is not adequate. With this, I now move to a third scenario, and here in this section, I am going to discuss one pathology which specifically occurs in the adolescent age group. It is not such a common pathology, so I don't think all of you would have seen this, but the incidence is increasing, and I will come to that in a moment. So this is the typical presentation, a 12-year-old male presenting with vague knee pain and limp, with an insidious onset, slightly high BMI, around 28-30 BMI, has an antalgic gait with outtowing, but there is a poor vague localization of the pain. Knee x-rays were obtained, normal. He was treated symptomatically with painkillers, calcium, vitamin D, etc. Few days later, this 12-year-old had a trivial fall, following which he had a severe pain in the thigh and groin, and he had inability to bear weight. And this time an x-ray of the hip was taken, and look what has happened. Okay, so uh, most of you might be knowing what this condition is. So this is a condition called slipped capital femoral epiphysis. And in this case, by the time the child has presented to us, this slip has become unstable and it has become severe. Okay. So a bit about slipped capital femoral epiphysis. It is a pathology, a hip pathology, which occurs specifically in the adolescent age group. We see it only in the 10 to 16-year age group. We don't see outside this age group. It occurs more often in children with high BMI. So with increase in incidence of adolescent obesity, the incidence of SCFE is also increasing. In most cases, it is idiopathic, that is, we don't find any underlying cause. But in a few cases, about say 5 to 10% cases, we may find an underlying endocrinopathy. Most commonly, the endocrinopathies which are associated are hypothyroidism, hyperparathyroidism, which may be associated with, which may be a secondary hyperparathyroidism of renal osteodystrophy, or in growth hormone deficiency children who are currently on growth hormone therapy, and in adiposogenital syndrome. So these hormonal associations need to be ruled out in every case of slipped capital femoral epiphysis. Now, how we treated this child? So this needed an extensive surgery, wherein which is called safe surgical dislocation. So here we actually need to dislocate the hip joint. We need to get the femoral head back in position, and then we need to fix it with screws like this. And this child or this adolescent went on to have very good outcome. But not everybody would be lucky like this. In severe and unstable SCFE of this nature, there is almost a 25% risk of avascular necrosis, which will destroy the hip for life. I mean, once an avian occurs, that hip is not salvageable. So the question is, how could this, SCFE converting to severe, this severity and this instability, how can it be presented? And so I will present a very similar case wherein the diagnosis was picked earlier. So similar presentation, 12-year-old male with knee pain, insidious onset, high BMI, antalgic gait with outtowing. The key message I want to give across in this section is, whenever there is an adolescent with knee pain, especially when that knee pain is not very well localized, always suspect a hip pathology. And for that, a very simple, quick screening clinical test that you can perform on table is something known as the Fadir test, which is a short form for flexion, adduction, and internal rotation. So if on flexion to 90 degrees, adduction and internal rotation, pain is elicited around the hip joint or the groin, it indicates that it is a hip pathology. In such cases, it is mandatory to obtain a X-ray of the pelvis with both hips. And if you drop lines over here, on the normal side, what you will see is that there is some portion of the femoral head which is lateral to the superior femoral neck. However, on the side of the SCFE, the line completely misses the femoral head, and that this sign, radiological sign, it is diagnostic of SCFE. Also on the frog leg lateral view, it is clear that this head is slipped off the femoral neck. Look over here. The neck is in a straight line with respect to the neck, but here it looks to be slipped off. And in these cases which are picked up earlier, so this is a stable, mild slip. In these cases that are picked up earlier, a surgery, a minimally invasive surgery called in situ pinning is feasible, wherein what we do is we put a wire into the slipped femoral head, and over the wire we then put a screw in order to stabilize this slip. So the femoral head cannot slip any further. And just look at the size of the incision. So because we picked this up earlier, and the complication of this getting converted to a severe and unstable slip was avoided, we could get away with such a small, almost a 1-stitch or 2-stitch surgery as compared to the much more extensive safe surgical dislocation. So to conclude this section again, Hip pain is often referred to the knee joint. That is because of the common innervation by the obturator nerve, and therefore any case of knee joint, always suspect a hip pathology and examine the hip joint as well. Rule out an SCFE in every adolescent with hip or knee pain. Early referral facilitates minimally invasive surgery in the form of in situ pinning as compared to more extensive surgery when it is a late referral, and misdiagnosis can lead to severe complications in the form of avascular necrosis. With that, I come to another extremely common presentation in our OPD. I think the incidence of adolescent back pain is also, increasing exponentially. Almost every day, I am seeing, 3, 4 children, adolescents with back pain. Definitely, the prevalence of, adolescent back pain is increasing. And there was a recent, population survey which showed that almost 50% of the adolescents surveyed reported some level of back pain, some severity of back pain at some period during their adolescence. So that's the incidence of back pain that we are seeing. Now, what is the cause of this back pain? Majority of these are postural, also called as muscular back pain or mechanical back pain. Okay, and this postural back pain, the incidence has increased because of the increased use of screen devices. So the screen devices, the children, they watch the mobiles, they watch the tabs, and often they watch it in a very bad non-ergonomical posture, and that is the primary cause of postural backache that has been detected. A few cases may be pathological, and amongst the pathologies, the most important ones or the most common ones are infection, that is TB spine, then spondylolysis, scoliosis, and in very rare cases, tumors of the spine. So these are the causes. So how to differentiate your postural back pain from your pathological back pain? So these are the red flags to look for. If the back pain presents in children less than 10 years old, or there is fever systemic signs, or night pain, duration is more than 4 weeks, or there is neurological deficit, or there is unexplained weight loss. All these, red flags should raise your antenna and should, help you to decide whether further investigations are needed. A very simple screening test that you can do in your OPD to differentiate between the two is this coin test. So just drop some object on the floor and ask the child to pick up the object. If the child keeps the spine rigid and picks up the object only by flexing the knee and the hip, it means that you are dealing with something more serious, and in those cases, always it is advisable to investigate further. What is the treatment? What is the primary treatment of postural back pain? So, what you can do in your OPD is, number one, give advice regarding proper ergonomic posture. And so the number one advice I give is, restrict the use of screen devices. And even if you give it for some period of time, make sure that the child watches the screen devices in a proper posture rather than in a non-physiological posture. The best ergonomic posture is something called as the 90-90-90 posture, in which the child sits upright with the back completely resting against the backrest of the chair. The hip should be flexed to 90 degrees. The knee should be flexed to 90 degrees. And the height of the chair should be such that the feet should be placed flat on the floor. So this is the ideal ergonomic posture. In addition, I always advise parents to get for their child a sitting arrangement with a elbow rest. That is very helpful. Thirdly, if the child is using a screen for, say, online classes or anything, then make sure that the screen is at the eye level, and also make sure that the keyboard and the mouse is within arm's reach. The child should not stoop forward either for using the keyboard or mouse or for writing. So these simple, instructions need to be given regarding the ergonomics. Secondly, regarding the backpack, another very important cause of back pain, make sure that the child is carrying the backpack with both straps on. Also, make use of a backpack with a waist strap. Okay. Make sure that the backpack is not drooping down. It should sit high above the buttocks, and the maximum weight of the backpack should not exceed 10 to 15% of the body weight. So these are some instructions regarding the back. Instructions regarding the backpack are the main instructions that I always give. Additionally, some simple exercises may be carried out: hamstring stretch, plank, bird dog. These all help to strengthen the paraspinal muscles and also strengthen the core muscles. So these are helpful in relieving postural back pain. Coming to a few pathologies. So what is spondylolysis? It is a common condition. It's not such an uncommon condition. It's more commonly seen where there is a repetitive extension loading, and the classical clinical feature, there is pain on extension. So that is a classical clinical finding in spondylolysis, and it occurs due to a stress fracture in the pars interarticularis. So if you look at the spine, okay, so here you can see, in this L4, there is a small gap over here, and this is usually diagnosed on X-ray, but if on X-ray it is not visible, then a CT scan will certainly show it much more clearly. So spondylolysis is not such an uncommon condition in adolescence, and if picked up early, it can be treated very well conservatively as well. TB spine, that is something we always have to be on the watch out for. So ask regarding constant pain, night cries and rigidity. Do an ESR CRP, but the gold standard investigation for a TB spine is an MRI, which will clearly show the early destruction of the vertebral bodies and soft tissue abscess. Finally, the third pathology in adolescence you have to be aware of is scoliosis, which can easily be identified by noting a rib hump on doing what is known as the Adams forward bending test. So these are very simple, tests which you can do in your OPD. Number one is the coin test. Number two is to look for pain on extension, which tells you about spondylolysis. Number three, for TB spine, again, you may ask regarding night cries, and for scoliosis, do a forward bending test. This is in brief the algorithm for management of back pain. So if there are no red flags and examination is normal, it is probably a postural back pain which can be treated with NSAIDs, good ergonomics, physiotherapy, and instructions regarding backpack. If there is a pain on extension, suspect a spondylolysis, investigate accordingly. And if there is a severe rigidity and there is night cries, etc., then do an MRI, rule out a spinal infection. With that, I quickly go into the last section, and here I won't take too much of your time. I know I have already crossed my time, but something I need to tell you about is sequelae of childhood infection. So many times what happens is we see osteomyelitis or septic arthritis in early childhood, and these children are later, we fail to follow them up. And what can happen if we don't follow them up? That's what I want to show. So this is a 15-year-old male who had a history of distal femur osteomyelitis in the neonatal age group, landed up with a distal femur growth arrest, which was not identified. After the infection was treated, it was assumed that things are all fine, the infection has settled, and he was, discharged from follow-up by the treating orthopedic surgeon and the pediatrician, but now lands up in the adolescence with a very significant leg length discrepancy of 12 centimeter. So you can see that, the femur is significantly short as compared to the other side. And in these cases, we needed to do something called as lengthening. We did the lengthening over the nail. So we put the fixator, we lengthened it, and then over a period of time, the bone reformed and the bone was elongated. So this was one sequela, one possibility which can happen due to a growth arrest. Sorry. Another case I will show you. This child had a proximal tibial osteomyelitis at 2 years of age. Later was lost to follow-up, but then presented with in adolescence with progressive varus deformity. And if you look over here, there is some irregularity that you can see in the growth plate over here. We got an MRI done which showed that there is a bony bar or a scar which is crossing the physis and which is tethering the growth of the inner half of the physis. And therefore, in this case, we needed to do something known as the bar excision. So that the bar that was excised. And in order to correct the residual deformity, we then applied this 8 plate, and over a period of time, the deformity then corrected. Okay. So these are two cases of, the infection settled in early childhood, but, then presented with sequelae in childhood. So conclusion, bone and joint infection in early childhood needs to be followed up till skeletal maturity. Growth disturbances can lead to deformity and leg length discrepancy later on in life after infection. So I'm sorry if I overstepped my time, but these were some scenarios which I thought that you do commonly see in the OPD, and I hope that we can, you can treat this at your level in a much more effective way. Thank you so much.
Excellent. Excellent session, sir. Thank you very much for such a comprehensive and clinically relevant presentation covering common yet missed adults and orthopedic problems. Most importantly, it reinforced that early recognition and timely referral can prevent complication and allow simpler and minimal invasive treatment. Over to our chairperson, Dr. Satish Agrawal, sir.
Thank you, Dr. Shruti ma'am. I written in the chat box only, such a nice presentation. Although subject is not very common to us, the conditions are very common to us, but you made it so simplified. The test are so simple. And the first thing you started with the common to uncommon and how to make difference between normal and abnormal. Here's the thanks to you and a nice deliberation. Now the question over to Shruti ma'am to take up the questions.
Yeah, so now we can ask questions. We have few questions in the chat box. Dr. Galgali has asked, does untreated rigid flat foot result in early onset of arthritis of ankle? Apart from pain and impairment of sports performance, are there any other complications?
Yeah. So rigid flat foot, number one, it is painful. Okay. So in the adolescent age group, these kids will come with pain. And why does the pain occur? The pain occurs because in the rigid flat foot, there is a bony bridge across two bones. So, in order to compensate for the loss of motion at that joint, what happens is that the other joints are excessively stressed. This is what leads to pain. But your question is very relevant if left untreated at that point of time due to the excessive stress on the other joints. In the long run, it may not happen in adolescence, but definitely in early adulthood, say around the age of 35, 40, natural history studies of rigid flat foot have shown that they do tend to land up with arthritis. So arthritis is definitely a potential complication of untreated rigid flat foot. Though as pediatricians, we may not see it in our practice, but adult, foot and ankle or adult, physicians are likely to see this arthritis coming on later on. So that's the importance, of treatment being done in the adolescent age group itself. It does land up with degenerative changes later on.
So well said. So we have another question from Dr. Ram Bharat, sir. Flat foot doesn't cause knee and calf pain. Then what causes of knee pain due to improper footwear?
What causes of?
Knee and calf pain. If flat feet doesn't cause any pain, then what is the another reason? Is it like due to improper footwear or anything else?
See, knee pain firstly can be due to localized, things around the knee. There are almost knee pain. The differential diagnosis, there can be almost 20 different conditions which can lead to pain around the knee. Of course, yes. If there is knee pain, you have to look at the foot as well and, assess whether the child is landing in an abnormal posture. But having said that, generally, flat foot has not been found to be the primary etiology of knee pain. It is a bit of a misconception. There are, studies which have been, conducted on that, and in most of the cases, we do find localized pathologies around the knee which lead to knee pain. They can be, overused tendinitis, like say an Osgood-Schlatter syndrome, or so where there is a tenderness on the tibial tuberosity, or there is something called as the patellofemoral pain syndrome, which occurs due to weakness of the quadriceps muscle. So you have to not blindly attribute knee pain to a flat foot just because the child has flat foot. What I'm trying to convey over here is a symptomatic flat foot will specifically have pain on the medial and lateral border of the foot. When there is a knee pain in association with the flat foot, you have to rule out any pathology around the knee before you say that that knee pain is because of the foot.
Yes, yes. Understood. So it is another question related to the nutritional decades. Like after 8 years of age, shall we send for the chest deformity for surgery?
Chest deformity.
Chest deformity.
Pectus.
Pectus. So, okay. So, pectus is another ball game. Generally what happens is, firstly, frankly, pectus deformities are not managed by orthopedic surgeons. They are managed by the CVTS surgeons. But anyways, it is very rare in rickets for us to see a pectus of such severity that it is going to lead to need a correction. Okay, most of the pectus deformities whether it be excavatum or carinatum, are not that severe deformities. They can be treated with just, observation. And another thing about pectus deformities are they tend to remodel for a much longer time. The reason being the growth of the spine and the rib cage, it extends much longer than around the lower limbs. So the growth of the spine continues for about 2 years after the physis around the lower limb, distal femur and proximal tibia, they close. Therefore, you can expect remodeling of pectus deformities for a much longer time as compared to the lower limb deformities. Lower limb, the problem is that the physis close much earlier, and therefore the importance of early referral in lower limb deformities.
Yes,
Pectus,
yes,
I
yes.
think you more or less you can choose to observe for remodeling, and generally they are not of that severity that they are going to need any aggressive treatment.
Yeah. So we have few more questions. Can I ask? Chitra madam?
Yeah, Dr. Preeti had asked 2 questions. I think they are important.
Yeah. So how do we differentiate physiological versus pathological adolescent scoliosis?
Okay. So, frankly, there is no such, thing called as a physiological scoliosis. But yes, I mean, sometimes, scoliosis can occur because of back pain. Secondary to back pain, you have a paraspinal muscle spasm on one side, asymmetrical, and that leads to what is known as a scoliotic list. So this pain is because of this scoliosis is because of muscle spasm and not because of any structural deformity in the bony spine. Now, in such cases, more common than not, we calculate an angle called the Cobb's angle. And this Cobb's angle, if it is less than 20 degrees, we assume that it is not a structural scoliosis. And in such cases, if the child has a backache and we take measures to relieve that spasm, okay, by giving, say, hot fomentation or, muscle relaxants, then this scoliosis, it corrects itself. So number one, it is less than 20 degrees in magnitude. There is an angle called Cobb's angle that we measure in order to calculate the scoliosis. Number two, it is associated with back pain and muscle spasm, and once we relieve that spasm, this scoliosis goes away. So that is how you can differentiate. Other thing you can do, which may not be possible in the painful state, is you ask them to do side bending. Okay, and on side bending, if that scoliosis corrects again, then it indicates that probably it is a non-structural scoliosis.
Yes, we have very enthusiastic participants. More questions now. What's the earliest age to recommend insoles for flat foot?
Okay.
And
So yeah.
Hollis
So flat
valgus.
feet, you see, I think that's most of us have a knee-jerk reaction that a child with flat foot comes in, we give insoles. Now, it is important to understand what is the natural history of flat feet. Now, if you look from early childhood, at the age of 3, if you take a population survey, almost 60 to 70% of children will be having flat foot. Okay, that's the incidence of flat foot. Now, this incidence keeps on decreasing with age. And definitely at that age, there is no indication to give insoles. Okay. Insoles, I think, should be considered only after adolescence. Okay. Because by that time we expect the that physiological flexible flat foot to resolve and the arch to reconstitute by that age. If beyond that age the arch has not reformed, then you may prescribe the insole. And even within that, there is still a controversy whether insole should be prescribed to all adolescent flat feet or whether it should be only prescribed to symptomatic flat feet. So that, I think, it varies depending on physician preference. But yes, beyond the age of 10, if there is a persistent flat feet, then you should prescribe insoles. I think so. Before the 10, I think the evidence is very,
Not
green.
less. What is the treatment of hallux valgus
Okay.
and
So,
how common it is?
yeah, I wouldn't say it is very common, but yeah, it can occur. Now, hallux valgus, again, you have to assess whether it is progressive, whether it is worsening, or what is happening. So the first instruction I give in cases of hallux valgus is to the parents to buy shoes with a very broad toe box. Okay, the shoes should not be cramped in the front. Number one. Number two, if in fashionable adolescents, if they're wearing high heels, that should be strictly avoided, because with high heels, what happens is the foot gets, kind of slides into the toe box anteriorly and your toes get cramped. So that should be avoided. Thirdly, in hallux valgus, you may prescribe something known as a toe spreader. So toe spreader is a kind of a simple, silicone ring which you can slip between the great toe and the second toe, and that you can, and over that you can wear your shoes. So that is available, toe spreader, or there is even something known as the bunion splint which can be prescribed. So that's for hallux valgus. However, in very severe cases of hallux valgus, even surgery is performed occasionally. It is very rare, but it may be performed. But that is done only after skeletal maturity and after complete closure of the growth plate. Because the surgery that is done in hallux valgus, it can damage the growth plate and can restrict the growth of the first metatarsal. And therefore, even if surgery is needed, it is after skeletal maturity. But most of the times, conservative measures they suffice.
Yeah. Sir, I would like to ask one more question. Like, what are the common mistakes by pediatrician while ordering imaging before referral? Like, are we supposed to order X-rays, and what type of X-rays we can?
So, I mean, depends on the condition that you are doing it for. So, if you are doing it for, say, diagnosing rickets, obviously you can do it, no problem. And most of the pediatricians, they prefer to get X-ray of the wrist joint rather than the knee. That's fine. That's completely fine. I can't think of any specific errors which are commonly performed, but I think you're well justified to order imaging if you feel the need to.
Sure. Okay, sir.
Do you have any specific pathology in
Pandrikar
mind?
had asked some question. Pandrikar sir had asked some question.
Yeah. How common is slipped capital femoral epiphysis?
Yeah.
That is the question.
So see, slipped capital femoral epiphysis till a few years ago, or I would say about 15 to 20 years ago, it was not such a common pathology. But I think, the incidence has increased, and that corresponds to the increase in incidence of adolescent obesity.
Obesity,
Okay.
yes.
There is a direct correlation between the BMI and the occurrence of SCFE. So if you see how common it is, yes, it is still not that common. But we as pediatric surgeons, I would say that I treat about 4 to 5 cases of SCFE per year. That is my average, how much I see. So as compared to, say, 1 or 2 cases in my whole residency in KEM 20 years ago, that it has definitely increased. The point over SCFE is, though it is rare, it is important to keep it in mind and pick it up early, because the consequences of misdiagnosis can be very serious in cases of SCFE.
Yes, truly said. Sir, but like, how quickly we can find out this slip capital femoral epiphysis in busy OPDs? Can you highlight
As
that?
I said, just do that Faddeer test.
Faddeer test,
Flexion,
yes.
adduction, internal rotation. You do that.
Yes.
There is pain. Have a very low index of suspicion. Order X-rays right away. Secondly, any adolescent who is complaining of vague pain in the, say, groin, thigh, or knee. Okay, it may not necessarily be in the hip, even in the knee. Most of these children, they come with knee pain. Have a very low index of suspicion, and go ahead with your imaging. No harm in ordering that imaging.
Yeah. Yes.
And unilateral. It is the symptom is unilateral.
Unilateral.
Occasionally we can see bilateral, but yeah, more often than not, it is 20% of SCFs are bilateral. Yeah.
So we can take this last question now from Dr. Amok. Why is coccydynia more common in adolescents? What are the preventive measures?
Again, coccydynia is associated with poor ergonomics, So sitting on the hard benches, if the child is again not sitting in the 90-90-90 position and is sitting in the slouch position, then what happens is the majority of the force is transmitted directly to the coccyx. Okay. The coccyx is not actually designed to take load. Okay. If you are sitting in the 90-90-90 position with complete upright, it relieves the pressure on the coccyx, in fact. Therefore, correcting the ergonomics is the most important first step that you take when treating coccydynia. Additionally, then, during the acute phase, you have to give local measures like, use a soft pillow, hot sits baths, and local application of some liniment or gel or some things like that. And in the rare cases, you may need to do a local steroid injection.
Yes, rightly said. So the last thing is, if you had to give one key message to pediatrician regarding adolescent orthopedic referral, what it would be?
Okay. See, I think I'm quite, very, very pleased with the, kind of referrals that I receive from from pediatricians. I mean, they are, very well aware of most of the orthopedic conditions. And therefore, I wouldn't give any specific, ye ki, any change that I would expect. But yes, I mean, carry on, pick up these conditions as early as possible. Uh, but there are many things which you can treat at your level. Not every case needs a referral. Okay, as you saw, most of the cases, the preliminary management can be done at your level, but then you have to aware of which cases they will need correction and which
Correction.
need to be, referred further.
Yes,
And
yes.
Dr.
Thank.
Shruti, Preeti madam has raised a hand.
Yeah.
Ma'am?
Yes, ma'am.
Yes, Dr. Sandeep, I was just asked you about the question about scoliosis because when we read from Western literature, we have said that between 10 to 16 years, there's an entity called as adolescent idiopathic scoliosis, and the prevalence of which is around 1 to 3%. In my own clinical practice, I have never come across this. So as you were talking, I was just wondering, and I'm sorry, I just did a quick PubMed search for this, and I just saw that there was a 2022 paper which said that the prevalence is very low in the Indian population because of the genetic causes. So I'm feeling a little relieved that I've not been missing. So it's just around 0.31% or so, because sometimes they come with these a little bit of change in their posture, the body image issues. So I was just wondering why I am not seeing this. So that is why I just asked
Well, the
this
reason,
question.
they are picking up
Yeah.
over there is they have a universal school screening program.
Yeah,
Okay.
exactly,
So
exactly,
even
exactly.
curves, of, about 10, 12 degrees, they define as scoliosis, though they don't treat
Yes,
those. And therefore,
yes,
that comes into the statistics. So majority of the curves that they diagnose are in the 10 to 20-degree range, which are not even
yes,
visible clinically. They detect those
absolutely.
curves by doing the Adams forward bending test. And on top of that, they have an instrument called scoliometer, which they, where they
Okay.
place that on the back and measure. And therefore, I participated in I used to sit in that, scoliosis screening clinic when I was at Philadelphia. So, I mean, you looked at those curves and you would wonder, what is the significance of identifying these curves? Most of
Absolutely,
the curves, I would say
absolutely.
90% were in the 10 to 20-degree range, which is of no clinical significance at all. So I
No
don't think we
clinical
should be,
significance.
unduly worried about
I
missing
know.
those in our
Yeah.
setup because they have no clinical relevance at all.
Right, right. Thank
Yeah.
you.
Thank you. Thank you, madam. Thank you, sir, for the clear clarification and valuable take-home messages. I now request Dr. Ram Bharat, sir, to kindly propose the vote of thanks.
Dr. Piali, madam.
Yeah, I'm there.
Yeah, madam,
So,
please.
so I just what I learned from the session is that um sometimes in our busy OPDs, we can miss out if a child says, I have a back pain. So what is our immediate response? Are wo bhari basta se hota hoga, and we miss scoliosis maybe or a kyphosis. So from what I'm learning is that then maybe knee mein dard hai, we often do not take out or elicit a history of sports injury or something of that kind. So a difference between what is normal and what is abnormal is what I have learned, that if you have a limp, if you have pain, pain is not normal. That is what I have learned. And like we do na, massage kar le, thoda sa thoda tel laga le, garam sek laga le, that should not be done. In fact, we should be telling these people actually to see the orthopedician. In fact, send them to our speakers, Dr. Sandeep here, and see that they are treated well. So, and of course, one thing is very important, because our children actually, they are with us for a prolonged period. A certain amount of counseling and bridging the gap between the pediatrician and the orthopedician is quite necessary. So when we go for school sort of screening programs, I think we should also go for screening of orthopedic issues along with the rest of the things. So school programs always look out for these small things. If a child is complaining of pain, do try to do a few screening tests, which Dr. Sandeep has just now told us about. So thank you, Dr. Sandeep. That was very enlightening. And thank you, Maha, for inviting me.
Over to
Thank
Dr.
you.
Ram.
Thank you, madam. I am deeply grateful to Dr. Sandeep Vaidya sir, today's speaker, for nice and elaborative talk which covers so many common conditions like flat foot, backache, knee pain, and guided about several key things like correct posture, what should be weight of backpack. Now we can definitely convey this formula of weight of backpack to concerned school authorities, because many kids are suffered because of back pain and neck pain because of this heavy backpacks. I extend my gratitude to Dr. Satish Agrawal sir, our moderator, for crisply covering all the pointers of speaker's talk. Also grateful to Dr. Shruti Kalkekar for nice moderation of the session. We are grateful to our guest, our own Dr. Shailaja Mane madam and Dr. Piali madam for their valuable presence and valuable advice by Dr. Piali madam about including orthopedic problem screening in regular school visits. We are deeply honored with valuable presence and blessings of Dr. R.N. Sharma sir and Dr. Preeti Galgali madam. I'm grateful to our guides and advisors, Dr. Jayant Pandharikar sir, Central AHA EB members, Dr. Chitra Kulkarni madam, MAHA AHA chairperson, Dr. Suchit Tamboli sir, and I acknowledge with gratitude our all core member teams, Dr. Vaishali Shirishetty, Dr. Abhijit Bharadwaj, and also I'm grateful to all committee members, executive members, and all executive members of CT branches. And special thanks to Dr. Neha Singh for technical support. And also I'm grateful to all participants who have made this event successful. Thank you.
Thank you, sir.
Thank you.
Before we conclude, I would like to announce the details of our next MAHA academic webinar. Our next webinar will be on 24th of February, Tuesday at 9 p.m. The topics are adolescent vaccination will be delivered by Dr. Nishikant Kotwal sir, Nagpur, and rabies vaccination by Dr. Alok Gupta sir from Jaipur. We look forward to your active participation in this upcoming academic program. On behalf of MAHA AHA and Central AHA, I sincerely thanks our speaker, dignitaries, organizing team, and all participants for making today's webinar a success. Thank you all for joining us and have a pleasant evening and good night.
Good night.
Thank you. Bye-bye.
Excellent talk, Dr. Sandeep.
Thank
Excellent.
you.
Thank you,
for
ma'am.
having me. Thank you. My pleasure.
Thanks,
Thank
Lily.
you, sir.
Thanks, sir.
Yeah.
Thanks, Satish sir.
Thank
Thanks,
you.
sir.
Thank you very
Thank you,
much.
madam.
Thank you, Chitra
Yes,
madam.
thank
Good.
you.
Thank
Thanks
you
a
so
lot.
much, sir.
It
Good night.
started very well, and it was really invaluable inputs which you gave, and it is permanent on YouTube and in our recordings. We will upload this on our MAHA IHS channel as well, so that
Okay.
others also who could not attend will see it again.
Thank you, Piali madam.
Truly nice. Truly
Thank you,
nice.
Shailaja madam. Thank you, everyone.
Thank you, ma'am.
Thank
Thank
you.
you, ma'am. Good night.
Thank you.
Good
It was
night.
very informative. Dr.
Shall I
Yeah.
Sandeep,
end the
it was
meeting?
very simplified and very informative. Thank you.
Thank
Thanks a
you.
lot.
Thank you very much.
Congratulations, Dr.
Thank you. Shall we end the meeting?
Yeah.
Yeah, thank
Good
you.
night.